story. So my colleagues will be presenting the case, and the person who is with me is Dr. Raghuram from Andhra, who is one of my colleagues. He's the person who will be doing the main work, and Dr. Usha and Dr. Aravind are there at the imaging. So now can we show the PowerPoint? Get on to the first picture. First picture. What?
Hello.
This is not first. This is the first. Okay.
Hello.
Before this, did we take any fluoroscopy of the
Good evening
valve?
all. This is 33 years male who had a history of breathlessness and chest pain 4 years back when he was diagnosed with severe AR and was planned for aortic wall replacement. So in 2013, he underwent a sternotomy and found to have dilated aortic root and proximal aortic ascending aorta with porcelain aorta. So the surgery was abandoned. However, he continued to have symptoms, so he underwent Bental's procedure with composite conduit of 25 mm TTK Chitra wall and 26 mm unigraft tube in 2015. On the right hand side, we can see the 3D reconstruction of the CT images. Entire aorta except the Bental conduit part is calcified, we can see. So after the Bental surgery, he was relatively asymptomatic for next 2 years. Possible cause of the porcelain aorta may be the Takaisu disease, burnt out disease. Subsequently, after 2 years, he developed infective endocarditis of mitral wall with coagulase negative staph and was treated with ceftriaxone and gentamicin. He was also identified to have large submitral aneurysm along the posterior mitral annular plane, along with the thinned PML with non-cooptation of AML and PML causing moderate to severe mitral regurgitation. So he underwent mitral wall replacement using 27 by 29 mm onyx wall and repair of submitral aneurysm with bovine pericardial patch in July 2017. After surgery, he was apparently well for 2 months, and when he again started to have breathlessness on exertion, we progressed to NYHA class 4 along with the PND. And when he found to have large 12 mm medial mitral paravalvular leak, so he underwent device closure of medial mitral paravalvular leak in March 2018 with muscular VSD device 18 mm. He also had an episode of atrial flutter for which he required electrical cardioversion followed by amiodarone oral. After the procedure, he was apparently well for next 1 year and then again started to have breathlessness on exertion, NYHA class 2 since last 6 months. Currently, he is on furosemide, aldactone, carvedilol, warfarin and amiodarone. On examination, he is thin-built, cachectic with weight of 47 kg. JVP is elevated 7 cm above with prominent V waves, hyperkinetic precordium. Apex is in left fifth intercostal space in the midclavicular line. There are prosthetic wall clicks heard. There is loud P2 and pansystolic murmur across the right upper sternal border, grade 3/6. X-ray shows situs solutus levocardia, CTR of 60% with cardiomegaly, and we can see the calcified aortic knuckle along with the descending aorta. ECG shows ventricular rate of 60 per minute, QRS axis is 0, PR interval of 240 milliseconds, QRS duration is 80 milliseconds, and prominent LV forces. This is the transthoracic echo pictures. In the middle, we can see a pictorial diagram. So, this is the bovine pericardial patch with persistent submitral aneurysm. In the middle, we can see the prosthetic mitral wall. On the other side, we can see the previous paravalvular leak device, and there is another leak which is medial to the previous device. Sorry. So from the diagram, we can make out the device. The leak is located medial to the mitral wall, so it is very difficult to approach from the septal aspect.
So we see a
This is the fluoroscopic images during. Yes. Yeah. This is the fluoroscopic images done during the paravalvular leak device closure, and we can see the plane of the mitral wall is actually in this position, but because of the submitral aneurysm, the bovine pericardium is bowing into the LA. This is transthoracic echo picture showing large medial mitral paravalvular leak, and the leak was measuring around 7 into 9 millimeter. On the left hand side, we can see the 3D reconstructed pictures with the bovine pericardium, and the device of the previous paravalvular leak. So this is again 3D reconstructed images with the aortic wall at 12 o'clock position. On the right hand side we can see the tricuspid wall. On the left hand side we can see the mitral wall which is opening well. Posteriorly there is a muscular VSD device and there is that additional paravalvular leak. So final impression is redo Bental procedure in 2015, redo mitral wall replacement and repair of the submitral aneurysm with bovine pericardial patch in July 2017, post device closure of mitral paravalvular leak in March 2018, presently having large 9 into 7 millimeter posterior medial mitral paravalvular leak with large submitral aneurysm, well functioning aortic prosthesis, severe pulmonary arterial hypertension and moderate LV systolic dysfunction. Plan is device closure of mitral paravalvular leak.
My goodness.
So, actually,
really
let me
something.
tell you, this is actually a horror story for us. This gentleman has got a very young age. He had an entirely calcified aorta. The first surgeon, when he opened for an aortic valve replacement, he found the entire ascending aorta like a rock. So he just closed the chest and came off. The second time it was operated by one of the most prestigious aortic surgeons of our city. He is well renowned for his aortic surgeries, and he in fact conducts annual aortic surgical workshops for the last 8 years. So he did a very beautiful Bental surgery on the second occasion. He went on femorofemoral bypass, he went on total circulatory arrest, and he performed a Bental. Following the Bental, this patient was found to have a severe mitral regurgitation after some time, and they identified that there is a massive submitral aneurysm. So he went and repaired that submitral aneurysm with a bovine pericardial patch and put in anchored the valve onto the bovine pericardium. What is happening is that submitral aneurysm continues to enlarge bigger and bigger. Now I will go live on the, make the echo big, go echo big, full echo, the entire screen echo, full entire screen. Yeah, so what you see here, the tricuspid valve annulus is at a different plane, the mitral annulus is at a completely different plane. The second surgery, when he went in for that submitral aneurysm, again it was femorofemoral bypass with total circulatory arrest, lasted for 5 to 6 hours, and there was a great difficulty in accessing the heart. It was an amalgamated sort of chest, the epicardium to the chest wall. With great difficulty, they separated out, they went on cardiopulmonary bypass, and then they fixed that mitral valve. Visualization was very poor, so ultimately resulted in a residual submitral aneurysm. You can see the plane in which the bileaflet mitral valve is opening. See the plane where my previous Amplatzer muscular VSD is located, and see the remaining bovine pericardial patch which is just flinging here and there, and the entire thing is now an ventricularized atria. It's a ventricularized left atrium. That entire portion that Dr. Usha is pointing out with an arrow mark is actually functionally the left ventricle, but anatomically the atrium. Next picture. So you can appreciate that the entire the aneurysm is occupying the left atrium. So we thought there was no point in doing any transeptal puncture and attempting this, because if I do a transeptal, I will enter into the ventricular cavity rather than into the upper small left atrium. Next picture. So next picture. Next. Yeah, the previous one, Dr. Usha. Previous one. Previous. On a posterior plane, you can see how much of atrialization, ventricularization of that atria is seen. The left atrium is sort of squashed to one corner. The whole of the mitral valve and the disc, the VSD paravalvar leak device that I have put in is just floating at the roof of the left atrium. Next picture. So then we did a parasternal long axis. All these are recorded by Dr. Usha, and since she's not having a mic, I am talking. You can appreciate the plane at which the mitral valve is there. That whole thing on the posterior wall is the submitral aneurysm. Just to take the arrow a little bit above, Dr. Usha, little bit below the valve, little bit below. Yeah, that whole area is that aneurysmal submitral aneurysm. Next.
Dr. Shiva, we are still not
Next.
seeing the echo on full screen. Can we eliminate the fluoro and the hemodynamics while we see the echo, because those are fascinating pictures?
Unfortunately, this is the maximum that it can be
All
filling
right,
the screen.
please proceed.
It cannot fill any further.
Okay.
Yeah.
Please proceed.
Yeah. So now what we are seeing is the bileaflet mechanical valve, onyx valve, which is having an acceptable movement. Next picture. So this is that onyx valve. This is the normal opening and closing angle of an onyx valve. This is a very large onyx valve. It's a 27, 29 valve. Next picture. It's actually difficult to get an orientation of this heart because the mitral valve is not in its regular plane at all. You can appreciate that towards the atrial septum, there is a leak. There is a color flow into the left atrium. Next picture. So then we went in for looking at the device. Next. So this is the leak. So this is on around 50-degree rotation. The device, the previous muscular VSD device is seen, and anterior to that is this device. Let me also tell you, after I closed this device in March 2018, we did a repeat transesophageal echocardiogram in April 2018, and there was a perfect, complete closure. Then 6 months later when we saw, this man is from far away from Chennai, he's from like north of Vindhya mountain. I don't know which state he's coming from, but it is from North India. And 6 months later when we saw this residual leak. So this is the leak which is anterior and adjacent to the device. Next. Next. So we are magnifying that. Next. So this is the mitral valve. On the medial side is the device, and just anterior to that is the paravalvar leak, in the place where Dr. Usha is pointing. Next. Next. Yeah, so we will get a color flow now. Next. Yeah, this is the again 2D color flow. We measured, it was anywhere between various dimensions, 6, 7, 8 and all we got. Next. So this is the leak which is adjacent to both the valve as well as the device, anterior to the device. Next. Next. Yeah, that is the leak. You can see the separation, the previous picture. Dr. Usha, can you freeze it and show the gap? Freeze it in here. Freeze. Freeze button. Here is the freeze button. Yeah. Yeah. It's not freezing at all. Okay, it's a number. Okay, machine is also not working. Next picture. Yeah, next. Yeah, so this we put it on an X-plane, because in X-plane only we can put the echo navigator. So we just made a trial check that we will be able to get the leak in both the planes. Next. Yeah, next. Yeah, this is actually you can see the device, you can see the valve, and in that crevice is the paravalvar leak, where Dr. Usha is pointing. That is the paravalvar leak. Next picture. So in this plane, then we put the color. Next. Show the 3D color. Next. Yeah, next. Okay. So what we did was, at this part, this is actually after crossing, just hold on. So at this point, go fluoro big. So what we did was fluoro live. Obviously, we did an apical puncture because he's having a mechanical chitra valve ventral in the aorta, so I cannot come from aorta. The whole of the septal aneurysm is so much lifted up into the left atrium that if I do a transeptal puncture, I will go below the valvar plane into the ventricle. So I cannot do a transeptal puncture. So repeat transapical is the only option. So we went for a repeat transapical. So like basically we were holding the sheath and Dr. Raghuram guided this guide wire inside and he's advancing the catheter, and then we confirmed that it is definitely through the leak. You can see the parallel
Echo
3D
pictures.
echo here.
Yes, the echo picture.
Yeah, echo picture on the side. So the valve, the device, all are seen separately. Next picture. Then we advance the sheath inside. Next picture. And with the sheath, we are now recording the left atrial pressure. What you are seeing, the pressure is the left atrial pressure. Now go make the pressure big. So the left atrial pressure is systolic V waves of 50 to 52, mean of around 24 or so. You can see the tall V wave, steep VY descent, indicating that there is a substantial mitral regurgitation.
Very, very impressive. Dr.
So,
Shiva, just one
like,
question. In view of the previous procedure having completely closed the leak, and within 6 months, one's having a substantial leak enough to cause such severe LA mean pressure rise, even after we close this, what do you think will be the future for this patient?
I don't know. Is it Dr. Ashutosh Marva?
No, this is Dr. Ajay Swami from Pune. Ajay Swami from Pune.
Oh, Dr. Ajay Swami. I don't know Ajay Swami. I pray for this man. I don't know. See, the India's best aortic surgeon touched him and he said that I cannot again operate on him. It is like, you know, it is a sort of a shell-like chest. I cannot enter inside. I also don't know. I can only sit and pray that he doesn't get another leak. I am sure the logic tells that he is going to get another leak because it is the submitral aneurysm, the bovine pericardial patch is bowing every systole and diastole up and down. I am sure he is going to tear more and more, but I don't know what is the option. Cardiac transplant?
I don't know, because if they had so much
Young
difficulty
fellow.
accessing the heart the first time, even the transplant surgeon is going to have great difficulty in getting out the old heart by the time even if they do. I think that's the final option for him, is that only, but I think this is the best palliative option that we can give him right now. Please go ahead.
It's,
The best
it's
structural
actually, he
interventionist in India is
frightens me,
operating,
Dr.
so-
Ajay Swami. Actually, when he enters into my outpatient clinic, I get jitters and I sweat out on him. It is, see, the imaging is difficult.
Quite so.
To understand his disease is difficult. Everything is difficult. We took about 1 hour in his transesophageal to just identify the plane where it is. The mitral valve is not in the regular plane. It is just lifted up. Somewhere it is lifted up.
Yes, absolutely, sir. Please go ahead, sir. We will not interrupt you.
192. Yeah, we have given about 3,500, how much? 3,000 heparin. He was a little marasmic guy. So now I am going to put a device. See, the thing is, now my device has to be sleek and slim. It should not be bulky. And it should, see, the previous device is a very large profile device. Now this device has to be a little bit more sleek, thinner, and it should not trap the valve leaflet.
True.
So I am guessing that a multifunction occluder from the LifeTech, which is 14 by 12, the largest device, might be a better choice because it's a thinner device. I would like to get the opinion of any other persons who would give me any suggestions. The reason why I am choosing this particular device, zoom in, is that it is sleek in profile. It goes through a 7 French sheath. It is quite small. So it has got 2 discs. One of the discs is this is one disc and this is another disc. I am actually planning in such a way that this larger bulky device is on the LV
LV side, right.
and the thinner device is on the LA. What are the thought process of all the panelists, others?
So Anybody else has a comment? So we have just thrown the question open to the audience. Anybody from the audience? So there's one comment about an occlutect paravalvular device. Anybody else? We'll just address them all together. Yeah. So even I had this thought that possibly an AVP, but I think the largest size available in the AVP is only 8. So I was thinking whether of putting 2 wires and trying 2 AVPs, because we have no experience with this LifeTech multifunction occluder.
Okay.
There are
the
4,
problem about an AVP is
4.
that
AVP 1 to 4. So
the problem
yeah, please go ahead.
Please go ahead.
the problem about an the problem about an AVP 2 is that the AVP has got 3 lobes. There will be one left atrial lobe, one middle lobe, and left ventricular lobe. Now, if I position the middle lobe exactly across the leak, and if that stays perfectly there, then there may be a good closure. But if it completely slips out and one of the small waist is going to be clasping the device, it will not close and it will lead to a lot of residual leak. And moreover, now we have to understand that there are one large profile valve on one side, a muscular VSD device on the other side, and this is in the crevice. Now make the echo bigger, this echo bigger. So you can appreciate in that crevice we are going to go. So I was thinking that see, I'll show you how it opens out. Show me the zoom in. So when I going to open it, the first disc that will open out is the LA disc, and then I am opening it out. What is going to come is the LV disc. This LV disc is a slightly bulkier disc, which has got a fabric also inside. So let me put it in, and then let us see how well it looks like. The moment I come into the left ventricle, then I will lose my LA pressure, and there is no further documentation of LA pressure possible. Close it. So now I am going to about the occlutect dedicated paravalvar leak device. There are 2 types of devices. One is the twist design, and one is the waist design. We have used quite a large number of these occlutect devices in the past. They are more useful for the primary paravalvar leaks. Here the issue is TE ready live.
And for the pressure
So
also,
now
I had
I am
one
going-
out of the box thought, Dr. Shiva. We could have used an FFR wire, you know. The
Yes.
FFR wire will go past this and will give you the pressure from the LA continuously, and it can easily be retrieved.
Okay. Like, parallelly put in an FFR wire.
On the side, along the side of the sheath, you can leave the FFR wire pressure transducer into the LA, finish with the closure, and then retrieve the wire later. It's a coronary wire, so it will easily come
Okay.
back.
Now, are you live, doctor? Are you live? We are. And show me the device now. Show me my device. My device is approaching.
I think
Show me my
fluoro, we need
device. The
fluoro
device
full
is
screen.
approaching.
Fluoro
Can
full
we
screen,
see the
please.
echo
Fluoro
and-
full screen. If we go, then I cannot see.
Yeah,
Okay,
yeah.
okay.
Please,
So
please,
50%
please
okay,
speak
video
out.
okay.
50% echo I will show.
Yeah.
Yeah.
Show me my disc. I want my disc to be shown. I am still in the left atrium. By my pressure trace, I am still in the left atrium. I am slightly coming down. Where? Nothing is moving. Show properly, Arvind. I am totally relying on you. Okay, now I am coming into the left ventricle in terms of pressure. I am not convincingly seeing the device. Now I am actually going more by fluoroscopic picture. Okay, now I think it is fine now. Show me, rotate and show me Okay, now color. Now color. It crossed the first device first. No, but is the left atrial disc, I think the left atrial disc is caught because you see the fluoroscopy, each time the left atrial disc is jumping, but the right atrial disc is, the left ventricular disc is remaining held.
Staying there.
So it is caught, but it is still producing color flow, right? Show me the color flow. Is it looking any better than before or?
Sir, this is Dr. Srinivas. Can I make a comment, sir?
Please go ahead.
Please.
Yeah, please.
Sir, in this corner MF device, whenever we deploy this device, you don't have any control on the LV side disc.
Yeah.
Actually, you cannot straddle it like what you do for an AVP. So when you deploy this, actually what is there in the defect is right now is the connection between the low pressure disc and the high pressure disc. That is what is actually closing this VSD.
Yes.
So that is actually not a self-centering device. It's an eccentric device. There is no self-sensitivity.
Correct.
So that this leak would remain.
Correct.
It would
That's
not actually go away.
Cut.
So how about using an ASD device?
Actually, in this particular.
How
No,
about
no,
using
no.
an ASD device?
Actually, what you are telling is correct. It's not a self-centering device, and so it is actually the thin waist that is actually going across the paravalvular leak.
Correct.
But we should remember there are two discs on either side, which over a period of time are going to develop some sort of thrombus. It is something similar to closing a VSD with an ADO2 device. Very often there will be an acute angiogram showing a lot of flows, but 24 hours, 48 hours later when you go and revisit that patient, it looks slightly better. It is because there are two discs with two fabrics. Actually, in terms of position, if you see, this is exactly in the place where we wanted it to be deployed. So what I feel is, I will show the color now again. One more thing is I have also given heparin. So I would think after the heparin effect goes off, there may be a bit better closure. The problem about using an ASD device, it has got a 7 millimeter disc that will be protruding onto the left atrial side and close to about 5 millimeter that will be protruding onto the left, left ventricular side. A large bulky two discs and they may be trapping my the bileaflet mechanical prosthesis. Let me see. Actually now the leaflets are okay now.
But can I ask?
Please go ahead.
Yes, please,
Would
Dr. Krishnamurthy.
a smaller device of this type help? Because it will snug it, it will align more effectively into the orifice. Because
It
now
was
there is
looking
more-
actually, see the hole was measuring somewhere around, in fact in the outpatient clinic when we made a good echocardiogram, it was 9 into 7 millimeter.
Now you showed 6 only.
If, what is that?
Now you showed 6 millimeters.
Today, yeah, but this is not the best of the machine, Dr. Krishnamurthy. We have an Epic in the ground floor where, in fact, the previous, the PowerPoint presentation they would have showed you. Much better quality, good transesophageal echo, and it was quite a substantial size. So based on that 9 into 7, I wanted the disc to be very large so that as Srinivas pointed out, it was non-self-centering. So I should be able to cover out from, even if the waist of the device goes to one corner, I should be able to cover that disc entirely. In terms of anatomical position, I'm actually happy with this position because the leak was exactly in this location, anterior to the VSD device and medial to the prosthetic valve.
No,
The
Dr.
device is
Shiva,
sitting
that's
exactly in that
perfect. I
location.
think-
Now again put the color.
I think that is perfect as far as the
Color
position
na-
is concerned. Can I make a small suggestion?
Sure.
Sir, suppose we just gently push on the cable and try
Get the
to,
color again. We just have 2D.
if we gently push on the cable,
Push on the
and-
cable.
yeah, and try to close with the waist, because actually the waist of this device is very small. So whereas the second lobe, the what is there now on the LV side, has got a little more bulky part. If we can approximate, some of this leak may be caused
Yes.
by the traction of the cable. If we gently push the cable, don't you think if the two lobes approximate a
have-
little bit?
That exactly was my point, because
I have pushed it now.
the
Can
leak
you
now,
see?
Yeah,
Can
it
you
looks
see
in a
that now
different
I have-
position. Yes, I can see that. I can see that the
Shiva-
sheath has got little less traction on it.
I have,
So I feel that the leak might be slightly less.
I
if
have
that
pushed
happens.
it.
It looks better.
Shiva, this is Ashutosh. Can I just ask one
Actually,
thing?
yes.
You have two
Yeah,
leaks
Ashutosh.
here. Actually, one is through the device and one is from the side of the device. See,
the one on the side of the
yes.
device is between the waist and the LV disc, because there is gap there. It is a larger device. That's what I felt.
that leak from the side is not going to go. The one through the fabric of device, yes, there will be thrombus and it will seal off.
Sir, one more thing is this device can be deployed the other way also. You have a fabric on the LV side. So do you think that screwing the cable from the other side will approximate towards from the LA, so that the fabric will completely occlude the leak and you'll be able to get a better alignment, sir?
Venkatesh, this fabric is on the, right now is on the LV side.
Exactly, sir. So if you screw it on the
Now,
other,
yeah, so if, okay. Now what my logic was, the pressure is higher in the left ventricle, so the larger disc is on the left ventricle. Pressure is low on the LA, so the thinner disc is on the LA. So fabric is on the LV side and non-fabric is on the other side. I am not able to comprehend how, for example, if it is a VSD closure, I would like to put the bulkier portion on the LV and the thinner portion on the RV. If I am using this on a PDA, I'll put the bulkier portion on the aorta and the thinner portion on the PA. So by that logic, I should put this way only. How you feel that it may, if I reverse it, how it might work?
no, but this you have measured something around 8 millimeter or so. So you have overstretched the device by at least 5 to 6 millimeter. So
Okay.
so I mean, if you feel that
Can I make
because
a
now you
comment?
could see this, you could see a lot of leak on coming out. How sure after deployment that this leak will disappear is a
Yeah,
big question.
Sir, can I make a comment, sir? When we use this device
Yeah,
in a
I-
VSD position, sir,
Yes, please.
so both the discs approximate immediately, and some of this bulky LV disc which we actually deployed on the LV would approximate into the aneurysm. So it would close more likely. Here there is no aneurysm formation in this paravalvular leak. That is one point where it might not close eventually. So second is that how about using a VSD device which is more self-centering than this muscular VSD device?
The previous is also a muscular
Muscular
VSD device.
Yeah.
Now, what sort of muscular VSD device we can plan?
So it's an 8 millimeter that you have measured, sir. How about a 10 millimeter muscular VSD device?
Yeah.
10 or 12 depending upon the nearness to the leaflets, because it does not have that big LA and RA disc.
I
of
see.
VSD.
Now, make the echo bigger. See, now what I am seeing is that gap between the LV, between the disc and the, you see now I'll show. I have taken see this area. There is a gap.
Visible gaps.
Yeah,
That is
visible
because
gap.
that device has been pushed to one corner, sir.
Srini, another question that I have is whether there will be two adjacent holes, and because it is a torn bovine pericardium,
Okay,
It
additional
might
one
be
you are
sieve like.
it will be very tough for me to,
Yeah,
yeah, whether it was a sieve.
sieve like.
See, the hole is there.
3D image will help here.
That is the 3D he showed, Arvind showed a beautiful view. Now, I'll show it again. This is the 3D. I'll put it into anatomical position.
So next to your device, I think there is a
Hole, additional hole visible.
Whether,
Yeah.
Is it
see,
additional or is it the same?
in this
Yeah,
area.
this one, yeah, the point where the pointer is slightly above.
This
Yeah.
additional crescentic defect
Yeah.
is there.
So the thing is now how I will be able to, you know, go. Let me do one thing. Through the side of the sheath, let me try to put in a wire and see whether I'll be able to manipulate. But I'm very, very, like, you know,
Is total
skeptic
circumference
about what I can achieve.
Put another
See, this
device.
I think
area.
oversizing more.
I will,
Another larger muscular device may help.
muscular 10 mm device. I'll try a muscular 10 mm.
Yes, sir.
10 or
Let
12.
me see whether I can get it.
Sir, as you said,
all
you have
this-
already measured 10 mm in your OPD. So better to try 12 mm.
9 mm.
No,
9
12
mm. See,
12
one more
mm,
problem
not
is the previous the previous device is much more bulkier. So, like, you know, how the device will align towards this device, how much of space. Is there a memo part 10 millimeter waist muscular VSD device? Ask the memo part persons. Memo part. Srini, I would say you can go, see. I will I will try to take this device back, recross the sheath, recross the leak. I will try another device and then come back to you.
Yeah, sure.
Because
you
your
can,
lectures also should not get disturbed.
Yeah, we'll continue with the presentations. You can proceed and we'll discuss the case once you're done.
Yeah.
Thank you.
Now you see, this is after the suggestion by all of you, we decided to take this out. So we advanced the sheath inside and we took out the previous multifunction device. Next we took a 12 muscular VSD device. Next picture. So this was the original muscular VSD, and then actually I thought I am deploying correctly, but ultimately learned that I had deployed both the discs on the LA. Next. So then when we lifted it up, it actually went, this is the second deployment, I think. Is this the second one? Okay, second deployment. Next picture. Yeah, this is the final. Next. Okay, okay, final. Now we are having live echo on the other side. The quantum of leak seems to be a little less now than before. Dr. Usha and Aravind, both of them are saying it's slightly looking better. So can you do a 3D and show the 3D, Aravind?
Yeah, 2D looks significantly less
So-
than the previous one.
Yeah, so this is the 3D. Now show the mitral prosthesis. Just rotate the probe a little bit. Yeah, so you can see that the prosthetic valve is on the 10 o'clock. The previous muscular VSD is on the 5 o'clock, and the new muscular VSD is on the 3 o'clock. We are thinking about accepting this. Show a quick color before the temperature goes up on the probe. Color. Rotate and show. Yeah. So that is some sort of leak that is occurring in between.
It's much
I don't
better,
have
yeah.
too many options. I have to accept
Yeah.
it.
Yeah, this is a very good one. Surely acceptable.
So, so now I am releasing this device. Already my team has prepared the apical closure device. So right now, yeah, quickly the apical closure device. What is, wait. It's our stop. Six-four ADO2 and I want a regular ductus. Okay, 6-4. Come. So it's a 6-4 device, PDA device. There is also already one previous PDA device in the apex. Can you go to RAO? go to RAO and show the previous device, and then in relation to that device, we will come back. So we are closing this apical leak with a LifeTech PDA device. Contrast, get ready, sister. Flush it. Free, close. Okay. Did we flush it after we took out the cable? Okay. We are running a little late because of little complexity of the patients also. Sorry about it. And how many more lectures you have there?
7 more lectures remaining. 11. Yeah.
Like lectures. Oh, sorry. I think I'm partly responsible for the delay.
It's okay. There's excellent learning cases.
So I'm going to be using the previous PDA device as the okay. Now you get the contrast ready. So I'm going to be coming out. Reverse protamine with heparin with protamine. You are aspirating? Yes. Okay. Protamine ready. Keep injecting. Keep on injecting. Okay, just continue. Enough. Okay, now Sister heparin reverse. Don't inject any further. Your hands don't expose. Okay, put a finger pressure. Now take. Okay, put a finger pressure. So what we have done is show the hemodynamics bigger. BP looks okay. I don't have a PA pressure. I have not done a cath at all. Okay, so BP is okay. So right now we are reversing the effect of heparin in order to prevent too much of leak from the apical site. And now you show the echo big and show final color. Show a nice picture. I think that 45° or 50° was the best view. Slightly pull out and give the color. Yeah, color. Yeah, rotate here and there and yeah. I think this is possibly the result that we could achieve today.
Yeah. Good result. Excellent.
So we'll see you tomorrow with I'll be there in the hall tomorrow to be with all of you, and I'll personally come and greet all of you tomorrow. You can go ahead with your lectures, please.
Yeah, thanks a lot, Shiva. Excellent, excellent result. Thank you. And